Hello, I am Dr. Siddharth Sinha. Today I am going to be talking about injuries around the knee. Let's start with the anatomy. So the knee is the largest and the most superficial joint in the body. It is a hinge joint, allows for flexion, extension. The tibia and femur, which is the tibiofemoral joint, is the weight bearing part. The patella and the femoral condyles, which is the patellofemoral part, directs the pull of the quadriceps. The fibula is not a part of the knee joint. The stability is conferred by the collateral ligaments, which is the medial and the lateral collateral ligaments, which give us the varus and valgus stability, and the cruciate ligaments, which is the anterior cruciate ligament and the posterior cruciate ligament. These allow for antero-posterior stability. The menisci are fibrocartilage, which act like shock absorbers between the femur and the tibia. The medial meniscus is C-shaped and broader posteriorly than anteriorly, whereas the lateral meniscus is almost circular and freely movable and smaller, hence less prone to injury. The movements around the knee are flexion, extension, and some medial and lateral rotation. The primary flexors of the knee are the hamstrings, which include the semitendinosus, semimembranosus, the long head of the biceps, and the short head of the biceps. The secondary flexors are the gracilis, the sartorius, the gastrocnemius, and the popliteus. Extension is done by the quadriceps femoris. Now, one important concept to understand in the knee is the screw home mechanism. In this, the knee passively locks because of medial rotation of the femur condyles on the tibial plateau. Here you can see that as the knee is extending, it has a tendency of locking with the femur condyles. Here you can see the rotation where the tibia is locking with the femur condyles. This makes the whole lower limb a single solid column which is more adapted to weight bearing. With the knee locked, the muscles can also relax, making the knee joint not unstable. To unlock the knee, the popliteus contracts, rotating the femur on the tibial plateau, allowing flexion to occur again. The mechanism of knee injuries can be either through direct trauma to the knee or by indirect trauma with a valgus, varus, twisting or hyperextension type of force applied to it. Now to begin with, let us start with the condylar fractures of the femur. There are three types: the supracondylar fracture, the unicondylar fractures or the intercondylar fractures. So the first is the supracondylar fracture, in which the fracture is above the condylar part of the femur. In this, the articular surfaces of the femur remain intact. Only the metaphyseal region is fractured. Here you can see very clearly how we are demarcating the supracondylar region from the condylar regions. The second are the unicondylar fractures, which is fracture of either the medial or the lateral condyle. A special type of fracture called the Hoffa's fracture is a fracture in the frontal plane of the femur. Intercondylar fractures, which are these, are involving both the supracondylar regions as well as the condyles. They can be either Y-shaped or they can be T-shaped. There can be severe comminution also, depending on the energy of the injury. Direct injury to the distal femur produces intercondylar fractures, whereas indirect injury causes supracondylar and unicondylar patterns. This is showing the unicondylar fracture patterns, and this is the Hoffa's fracture in which the frontal plane is involved. This is a supracondylar fracture in which you can see that the articular surface of the knee is intact and so are the condyles. This is an example of a Hoffa's fracture in which you can see the fracture plane clearly running through the frontal plane. And this is a type of comminuted fracture in which you can see that a part of the joint along with a lot of the metaphysis with a lot of comminution is present. Now the diagnosis is typically pain, swelling, bruising around the knee, and the patient is definitely will be able to walk. Associated injuries must be ruled out, which include shaft of femur injuries, tibial shaft injuries, pelvis fractures. Radiography should be done to assess and confirm the diagnosis. The whole profile of the femur with the hip and knee should be visualized. Treatment options for distal femur fractures can be divided into operative or non-operative management. For unicondylar fractures which are undisplaced, a long leg cast may be given for 3 to 6 weeks followed by protected weight bearing. For displaced fractures, open reduction and internal fixation is always the choice. This can be done either using cancellous screws or Herbert screws. Herbert screws are a special type of screws which do not have a head. Alternately, a buttress plate can also be used. For intercondylar fractures in which the joint is disrupted, the aim is to restore articular congruity and prevent knee stiffness. This can be done by open reduction internal fixation using a plate, either a distal femoral metaphyseal locking plate, which you can see here, or a dynamic condylar screw or a condylar blade plate. Conservative management for intercondylars are rare and can be done by skeletal traction but can often lead to malunion. For supracondylar fractures, either a nail or a plate may be used. This is again an example of a supracondylar fracture in which a plate has been used for fixation. Complications of these fractures include knee stiffness, especially due to periarticular and intraarticular adhesions, osteoarthritis due to altered weight-bearing axis, and malunion such as in valgus or varus, which may later require a corrective osteotomy. Now the patella is the largest sesamoid bone in the body. It has 7 articular facets, which you can see here, which is functional in different ranges of knee flexion and extension. Surrounding it are the medial and lateral retinaculum. The function of the patella is to increase the mechanical advantage and leverage of the quadriceps tendon for knee extension. It also aids in the nourishment of the femoral articular surface, and it also protects the femoral condyles from direct trauma. The mechanism of injury to the patella can be either direct or an indirect injury. In the direct injury, the patient will fall directly on the patella, which will produce specific type of fracture pattern, which can be an incomplete, simple, stellate or comminuted fracture pattern. The displacement in this case is minimal due to preservation of the medial and lateral retinacular expansions, which does not allow the fracture to displace. There may be abrasions in the area, or open injuries may also be seen because of the superficial nature of the patella, and active knee extension can be preserved in these cases. The indirect mechanism of injury is a more common method in which the patella is fractured. Here, the fracture occurs due to forcible quadriceps contraction with the knee in a semi-flexed position, such as in a stumble or fall. The intrinsic strength of the patella is exceeded by the pull of the muscles and tendons, leading to the fracture. In such cases, a transverse fracture pattern is most commonly seen. The degree of displacement of the fragments suggests the degree of retinacular disruption, and active knee extension is often lost because the ret disrupted. A combined direct and indirect mechanism may produce a mixture of these injuries. Fractures of the patella can be classified based on the morphology of the fracture patterns. They can be an undisplaced fracture, a transverse fracture, a lower pole fracture, which you can see here, multifragmented fragments which are undisplaced, multifragmented fragments which are displaced, vertical fracture patterns, or an osteochondral fracture pattern. Clinical features remain the same. There will be pain and swelling over the knee. In case of an undisplaced fracture, there may be swelling and tenderness which is localized only over the patella. Crepitus can be felt on examination, and in case of displaced fracture, a gap between the fracture fragments may also be seen. An important examination finding is that of an extensor lag. An extensor lag is the loss of the terminal 15 to 30 degrees of the extension due to disruption of the extensor apparatus. There may also be bruising around the knee. Radiological evaluation can be done by ordering an antero-posterior view of the knee, a lateral view of the knee, and a skyline view of the knee. This will determine the fracture of the patella and help us classify it better. The treatment includes a cylindrical cast for undisplaced fractures. In case of two-part fracture, a tension band wiring may be done. A tension band wiring allows for early mobilization at the fracture site. The principle, as you can see here, is that when an eccentric load is applied on the tension band, the eccentric load is given by the quadriceps. The distractive forces which are seen on the fracture site, which you can see here in red, are converted to compressive forces, which you can see here in green, leading to compression at the fracture site and healing of the fracture. Tension band wiring also allows for early mobilization of the patient. Other options include a partial patelectomy. This is done in cases of lower pole or inferior pole of patella fractures, in which a part of the patella is excised and the extensor mechanism is repaired. Alternately, a total patelectomy in which the whole patella is excised may also be performed, but it is now rarely done. For comminuted fractures, encerclage, a total or partial patelectomy may also be considered. Complications of patella fractures include knee stiffness, extensor mechanism weakness, and osteoarthritis. The osteoarthritis here can be a patellofemoral osteoarthritis. The next important structures around the knee are the ligaments. The ligaments around the knee are often injured following sports. Different mechanisms of injury can injure different ligaments. The medial collateral ligament can be injured in a valgus force is applied. A lateral collateral ligament can be injured when the varus force is applied. The anterior cruciate ligament, which you can see here in blue, which is injured after twisting on a semi-flexed knee. O'Donoghue's triad include injury to the medial collateral ligament, the medial meniscus, and an ACL injury. The posterior cruciate ligament is injured when a posteriorly directed force is acting on a semi-flexed knee. We will talk in general about ligaments and the grading of injury. The ligaments can either tear on either of its attachments or through mid-substance. An avulsion fracture is when a bony fragment is avulsed along with the ligament. Now, grading of ligamentous injury can be type 1, in which the fibers are stretched, type in which there is an incomplete tear, type 3 is a complete tear, and type 4 is an avulsion injury. Now, the diagnosis of ligamentous injury can be very typical. There can be a history of fall while playing, followed by pain and swelling. The patient may report a sound of something tearing, followed by swelling, which is hemarthrosis, and pain at the torn ligament. There may be vague pain in case of cruciate injury or meniscus injuries, and the patient will also give a sense of the knee giving way. The patient will also be not able to pivot or run. Examination findings are very typical. Here, in case of a medial collateral ligament, we will see that the pain will be on the medial side and there will be tenderness along the medial femoral condyle. To test, we will perform a valgus stress test with the knee in full extension and 30 degrees of flexion. Similarly, for the lateral collateral ligament, the pain will be on the lateral side along with tenderness in the same region, and a varus stress test will be performed. For anterior and posterior cruciate ligaments, we will find that the anterior and posterior draw tests will help us elicit the diagnosis. To perform the varus or valgus stress test for medial collateral and lateral collateral ligaments, to perform the valgus and varus stress test to test for the medial collateral and lateral collateral ligaments, first the knee is tested in full extension. In full extension, a valgus and varus stress is applied and opening is seen in the opposite side. The second part of the test is performed with the knee in 30 degrees of flexion, and if there is any opening up on the joint compared to the normal side, then the test is considered to be positive. For the cruciate ligaments, we will start with the anterior cruciate ligaments. The anterior draw test is done with the knee at 90 degrees and the hamstrings relaxed. We must stabilize the leg and the foot and we must restore normal tibial step off. Normal tibial step off means that normally the tibia is slightly anterior to the femoral condyles. This will then give us a reference point, after which we can determine whether the knee is translating anteriorly or not. Following this, we should apply a anteriorly directed force and compare these findings with the other side. This test cannot be done in an acute injury, and false negative occurs due to a doorstop effect of the meniscus. Sometimes, in cases of a posterior cruciate ligament injury, this can be interpreted as a false positive draw test because often we may forget to restore the normal tibial step off. To perform the Lachman test, we must place the knee in 30 degrees of flexion. Then we can apply a anterior directed force and then assess the end point. If the end point is soft, then there is an injury. This can be done in or an acute injury, and it is more sensitive as compared to the anterior draw test. A pivot shift test can also be done to assess for cruciate ligaments. The posterior cruciate ligament is assessed using the posterior draw test. In this, the prerequisites remain the same as the anterior draw test, but instead of an anterior directed force, we are now giving a posterior directed force. We can also assess for a posterior sag, and we can also perform a dial test to assess for the posterior cruciate ligaments. On plain X-ray, there is often a soft tissue swelling and no bony injuries. An avulsion fracture may be seen where the ligament is attached to the bone. And stress views in valgus and varus can demonstrate an opening up of the joint in case of collateral injuries. MRI is one of the best methods to diagnose ligament injuries and can be used in doubtful cases where clinically the picture is not clear. A Segond's fracture is an avulsion fracture of the proximal lateral aspect of the tibia, which is pathognomic of an ACL tear. It represents the bony avulsion of the anterolateral ligament and associated with an ACL tear in 75 to 100% of the time. A Pellegrini striata lesion is a calcification along the insertion of the medial collateral ligament, which may indicate injury or degenerative changes. A tibial spine avulsion fracture, which you can see here, is the avulsion fracture at the ACL insertion on the tibia. Similarly, the posterior cruciate ligament attachment in the posterior aspect of the tibia can also be avulsed. A diagnostic arthroscopy and an MRI may also be done to test for ligamentous injury. The treatment in the acute phase is rest, ice compression, elevation and analgesics. Previously, conservative management was preferred due to suboptimal results for ligament injuries. But these days, with improved surgical techniques and instruments, surgical intervention and reconstruction are often used for patients with a lot of instability and high demands, for example, athletes. For conservative management, a cylindrical cast may be applied, which is appropriate for a grade 1 or grade 2 tear, and physiotherapy can be initiated 2 to 3 weeks after immobilization in a cast. Surgical management is always performed in a delayed manner and never in an acute setting. It is done 2 to 3 weeks following injury to allow the soft tissue swelling to subside and prevent knee stiffness. The reconstruction of ACL or PCL can be done using autografts or allografts such as the hamstring, patella, TFL, peronei, quadriceps, or even some synthetic materials. Repair of these ligaments are not done due to poor results. Complications include knee instability and osteoarthritis. Tibial plateau fractures consist of 1% of all fractures and 8% of fractures in the elderly. Isolated lateral plateaus fractures account for 55 to 70% of tibial plateau fractures. These are often due to road traffic accidents, and 1 to 3% of these fractures are open injuries. The mechanism of injury can be either a valgus or varus force coupled with axial loading, leading to disruptions as the force keeps acting on the knee. This can lead to disruption of the ligaments, and as the force keeps continuing, most structures can be affected. There are two classifications, one is the Schatzker classification and the second is the Holland-Moore classification. Clinical features are tenderness, swelling, deformity and inability to bear weight. It is very important to perform a neurovascular examination. In this, distal pulses of the dorsalis pedis and the posterior tibial artery must be palpated to assess for injury to the popliteal artery. The peroneal nerve, if affected, can lead to foot drop and can be injured because it courses around the fibular neck. There may be hemarthrosis. A compartment syndrome must be ruled out. There should also be a detailed assessment for ligamental injury, but it should be done once pain has subsided. Associated injuries include injury to the meniscus, the cruciate and collaterals, as well as distal femur fractures. On X-ray, you can see here that the whole of the plateau has been depressed, and here you can see a fracture of the lateral condyle. CT scans are done to further delineate the bony injury and plan for surgery. An MRI of the knee is done to evaluate the soft tissue and ligaments. An arterial Doppler is done to evaluate the vascularity and any vascular injuries. Non-operative treatment can be done for undisplaced or minimally displaced fractures. This can be done in the form of a cast application followed by a hinged knee brace and protected weight bearing for 8 to 12 weeks along with quadriceps exercises. Operative management aims at restoring the articular congruity and the tibial alignment. The choice of implant is dictated by the fracture patterns and can be either plates and screws, external fixator like an Ilizarov fixator, or a combination of these. Here you can see a combination of a plate and screw fixator. Here you can see a plate only. We must assess for ligamentous injury and repair if required. The complications of tibial plateau fractures include knee stiffness, infection, compartment syndrome, malunion or non-union, post-traumatic osteoarthritis, peroneal nerve injury, popliteal artery lacerations, and avascular necrosis of small articular fragments. The other segment of the knee consists of the menisci. The menisci, as I described earlier, act as the shock absorbers of the knee. They prevent the tibia and the femur from rubbing against each other and also dissipate forces which are generated around the knee. The mechanism of injuries for menisci are a person who is standing on a semi-flexed knee twists to his side, which leads to the injury. During this movement, the menisci are sucked in. As the rotation occurs between the femur and the tibia, injury to the menisci occurs. The medial meniscus is torn more frequently because it is less mobile, being fixed with the medial collateral ligament. Here you can see the menisci has different blood supply. One is the red zone, which is well vascularized, the red-white zone, which is partially vascularized, and the white zone, which is the least vascularized. The most common part of the meniscus which is injured is the posterior horn. With subsequent injury, the tear may extend anteriorly, and because the menisci are a relatively avascular structure, the injuries do not heal very often. If the injury occurs in the red zone, which has relatively better vascularity, the chances of healing may occur. But as you go towards the center of the menisci, the chances of healing reduce. The same principle can be applied while treating these injuries. We can consider repairing tears in the red zone, whereas in the white zone, often a part of the meniscus may need to be cut, which may be impinging around the joint, called a partial meniscectomy. The type of meniscal tears include a longitudinal tear, tears of the posterior horn, bucket handle tears, radial tears, and anterior horn tears. Of this, the bucket handle type is the most common type of injury. Meniscus morphology, such as discoid meniscus, meniscal cyst, and degenerated meniscus, are also more prone to injury than most menisci. The clinical feature is typically that a young patient who is engaged in sports presents with recurrent episodes of pain and locking of the knee. They may report a sudden jerk while walking or clicking, which is followed by swelling. There will be a history of twisting injury, after which the swelling appears overnight, and once subsides, the patient may not be able to extend the knee fully due to the torn meniscus impinging into the joint. Compared to this, whenever ligament injury occurs, there is immediate swelling. The history of sudden locking and unlocking with a click is diagnostic of a meniscal injury. On examination, we will find tenderness around the region of the joint line. Knee locking may be present, and attempts at forced extension may produce a sensation of elastic resistance and pain localized in the appropriate joint compartment. There may be associated wasting of the quadriceps as well. The McMurray's test, as you can see here, is done with the knee flexed and internally rotated. Extension is done for testing the lateral meniscus. Similarly, the knee is fully flexed and externally rotated to test for the medial meniscus. A positive test occurs if there is pain experienced by the patient or crepitus felt by the physician during examination in the knee joint. In the applique grinding test, the patient is asked to lay down prone and the knee is flexed to 90 degrees. There are two components to this test. One is the distraction component and one is the compression component. In the distraction component, ligament injury is assessed, whereas in the compression component, menisci injury is assessed. In the compression component, the tibia is rotated against the femur in a flexed position to assess for pain. The Thessalais test is done with the patient standing on the affected limb with support and is asked to perform internal and external rotation on the lower limb. If there is any pain, then it is suggestive of a meniscal injury. Radiological examination may be normal in most cases. MRI is helpful to detect tears and is non-invasive and very sensitive. Arthrography is rarely done in view of MRI, and arthroscopy can be done, but it is invasive. However, it allows direct visualization of the tear and can be used in cases where MRI picture is not very clear. The treatment of an acute meniscus includes rest, ice, compression and elevation along with analgesic. In case of a locked knee, manipulation under anesthesia may be done, followed by immobilization for 2 weeks and physiotherapy. If the meniscus tear is chronic, then a partial meniscectomy may be done to remove the torn part of the meniscus. We can consider repairs if it is in the red vascular zone, which is the peripheral zone of the meniscus, the red zone, and a total meniscectomy was earlier done in which the whole of the meniscus is removed, but it is not preferred these days. Now talking about knee dislocation. What is a knee dislocation? A knee dislocation is when the articular surface of the femur and tibia are not in contact with each other. This is a very uncommon injury and it signifies significant soft tissue damage leading to loss of all structural integrity in the knee, causing the dislocation. It is safe to assume that All ligaments around the knee are injured because of this high energy trauma. And we must always be careful of popliteal artery damage. Once the dislocation is reduced, we must watch the patient for up to 72 hours to check for late vascular compromise which may occur in these cases. Immediate reduction and slab application for 2 weeks along with close observation for vascular compromise for up to 72 hours is the treatment of choice for patients with knee dislocation. Extensor apparatus disruption involves the tearing of the quadriceps tendon from the attachment on the patella. The tearing of the attachment of the patellar tendon from the tibial tubercle. In both these cases, operative management using bioscrews or a bone to tendon repair is imperative. Now talking about patellar dislocation, the lateral dislocation is most common. Types of patellar dislocation include an acute dislocation, a recurrent dislocation and habitual dislocation. An acute dislocation, as you can see here, is often a lateral dislocation. There is a sudden contraction of the quadriceps with the knee in the flexed or semi-flexed position, and the patella dislocates laterally, lying on the outer surface of the knee. Here you can see this again, that the patella has dislocated laterally and is lying on the outer surface of the knee, and this player has spontaneously reduced it. The patient is unable to straighten the knee, and a prominent medial condyle of the femur is also noted. It may reduce spontaneously. The treatment for patellar dislocation is immediate reduction and immobilization in a cylindrical cast or knee immobilizer for 3 weeks. In case of an osteochondral injury or loose body, arthroscopic debridement or removal may be planned. Recurrent dislocation of the patella means that the patient will have multiple and frequent episodes of dislocation following the first episode of dislocation with more and more ease. Causes of recurrence include laxity of the medial capsule, defect in the anatomy of the knee which include either excessive joint laxity, a small patella, patella alta or genu valgum. Treatment involves multiple procedures involving both bone and soft tissue. It is important that we must evaluate the cause of recurrence and treat accordingly. A habitual dislocation of the patella means that the patella will dislocate laterally every time the knee is flexed. Underlying defects are very similar to those in recurrent dislocation. A shortened quadriceps may result in an abnormal lateral pull of the patella with the knee flexed. The treatment is again release of the tight structures on the lateral side, repair of lax structures on the medial side, and an additional check-in mechanism to prevent the redislocation. Thank you for watching this video. I hope you liked the content. Please like, share and subscribe to my channel.